So throughout this presentation, I'll go through all of these steps of the treatment journey and try to highlight some of the applications of AI for these different aspects. But first, I'd like to go into the methodology that's most commonly used for these types of analysis. Starting with, I guess, the most studied subject in our field, which is automatic segmentation of the tumor. Mainly thanks to the Brett's challenge, I think there's been a lot of work on this, and the general workflow looks a bit like this. We use a 3D UNet, which still is the cornerstone, I think, of almost all of the AI work. Transformers are picking up a bit, but I think we can still consider the 3D UNet as the main cornerstone there. We enter the MRI scans, pre-process them to align them in the same spacing, and remove the areas that we're not interested in. Use these as input to the network and show examples of segmentations as the output. And mainly thanks to this large body of work, we've gotten good at this, and AI has made a tremendous contribution into the leap that's been made over the past couple of years. And from our own work, but also, well, from all of this work in, for example, the Brett's challenge, we are now, I think, at a stage where we have really robust models that are widely available and that are practically matching human performance. For example, as you can see here, with DICE scores of over 0.9 and no significant differences between manually created incidence maps and automatically generated incidence maps. For the post-operative case, there's has been far less attention to this task, but in our recent work and also some work of others, we're starting to see that also for this far more difficult task, we're starting to approach human level performance. Here on the right, in the middle boxes, you can see the performance for experts, and here on the most right, you see the performance of the models, which is starting to get into the same ballpark at least. So in conclusion, for the segmentation task, I think we're now at a stage where we have excellent performance for preoperative multi-class segmentation and for postoperative enhancing residue, but there's still some work to do to improve performance for multi-class post-op segmentation and also in follow-up. But I'm fairly confident that with more annotated data that we'll be able to tackle this problem in the near future. So with this talk about, well, starting with automatic segmentation, it's all nice and well that we can now delineate a tumor, but what's the use of that for the clinical practice? And I think for most of these AI applications, it's not really about what a single tool does, but the things that having this tool enables us to do. So, for example, for the automatic segmentations, given that we are now able to automatically segment the tumor preoperatively for large data sets, this enables us to predict other outcomes of interest. For example, the IDH status or other molecular subtypes, or for example, the overall survival. One of the classical approaches is to use a feature extraction based on the automatic segmentations and combine this with clinical variables in a normal standard regression or maybe a random forest to predict our outcome of interest. An alternative approach is to use a fully of our 3D UNet model as input vector for our outcome prediction, or well, we don't necessarily need the segmentation task here. We could also cut off this upsampling part of the UNet and end up basically with a regression network, and we can use these to predict outcomes directly from the imaging. Finally, one other relatively common methodology is to, instead of predicting an image here or predicting segmentation here, to predict an image. For example, a contrast image for a patient where no contrast was given during the scan, or a pseudo-CT to do radiotherapy planning on. So with this introduction, we finally can get to, well, the applications within our clinical practice. Starting with diagnosis. I think that for the diagnostic process, one of the main game changers is going to be the AI accelerated reconstruction, which is going to speed up the acquisition times and hopefully lead to fewer incomplete scan series, more frequent scans perhaps, and also leave a bit of time for the advanced imaging that we all are so interested in. A second objective within the diagnostic area would be to predict the tumor classification before surgery. This could be used as a prognostic biomarker or for perhaps support the surgical decision making. And in lower income countries, it might also reduce the need for diagnostic biopsies. And for this task, as well also showed earlier this week, we're starting to get quite good at predicting the IDH status, but for other subtypes, there's still quite some room for improvement and perhaps a need for advanced MRI to get better at this. Another aim during the diagnostic process would be prognostics. So trying to predict, for example, the overall survival or the progression-free survival. While the direct impact of having these predictions for the treatment isn't perhaps obvious, it does provide more information to the patient. It's clear what the patient can expect. And perhaps it can help us to also fine-tune the follow-up frequency of our MRI scans. For a patient that's expected to have a long progression-free survival, perhaps we don't have to scan as often in the early stages. And shown here are some preliminary results where using a 3D convolutional neural network, using only the tumor area as input, we can get about the same accuracy as using all of the clinical variables. Imaging and none of the clinical variables. So hopefully by combining these clinical variables and perhaps using a slightly more advanced model, we'll be able to further improve on this. Then, well, I think we're already almost halfway our talk, and we finally got to the first treatment of the patient, namely surgery. And this is a bit closer to the work that we're focusing on in our project, in the PICTURE project, where we have collected data from over 15 national and international hospitals, and well, including over 1,500 low and high grade patients. And for all of these patients, we've started off manually delineating, but are now working on a semi-automatic segmentation workflow, thanks again to the use of AI. We use this data set, for example, to predict the biopsy decisions. So one of the, well, not often investigated, but really important decisions during the treatment is whether a patient is going to receive a surgical resection or a biopsy. And here we see that for now, at least the top performer is the AI-assisted method, where we use AI-enabled segmentations with a classical feature extraction, for example, the size and the location of the tumor in the brain overlap with anatomical structures. And we can see that we get an area under the curve of about 90% for these cases. And this could, for example, be used to aid clinicians in their decision. If the surgeon agrees with the model, then it's probably okay to just continue. But if he disagrees, perhaps it's good to get a second opinion, talk with a colleague, and see what the motivation is of deviating from the standard. Another application that's enabled by automatic segmentations is the creation of resection probability maps. And thanks to having these automatic segmentations, we're able to include far larger cohorts in the data set, and we're able to apply it to new patients without having to first delineate the new scan. So what you see here is a resection probability map projected on the tumor of a new patient. where in red you see the areas that are most likely to be left behind as residue in patients with a similar tumor, and in green are the areas that are more commonly resected. And again, this can aid the surgeon in, well, checking whether his decision on where to stop corresponds to the average. We're currently working on further personalizing this by being able to filter down also on the specific age of the patient, or further digging down on the tumor grade, for example, and creating personalized resection probability maps of as similar patients as possible, so that we can compare also the survival curves of those patients and use that as a frame of reference for a current patient. Finally, we can use a similar approach to compare, for example, the resection strategies used in different hospitals. So here we've created resection probability maps for over 10 hospitals across the world, and try to identify whether there are differences in their practice, which could lead to, well, discussions on which of the approaches is best. Then we continue to the second localized treatment of our glioma care, which is radiotherapy. And again, I think that the role that AI can play here can be very big. Just like the automatic segmentation work on the tumor, we see quite some progress in automatic organs at risk segmentation, and also on automatic generation of the CTV, perhaps also based on more advanced MRI scans and tumor growth models. And another direction of research we see quite some development is the generation of synthetic CTs. And this is important because we can use these synthetic CTs that are generated based on MRI scans to calculate our dose distributions. And by automating all of these steps during the planning phase, we could actually start to further personalize the treatment and change the planning every day or every day of treatment, instead of just planning once before treatment starts. For example, with the use of an MR-Linac, you can scan the patient every day it comes in, reassess the current status of the tumor, and adapt your radiotherapy plan accordingly. Then, well, we're getting to chemotherapy, which is a bit further out of my comfort zone, so I'm going to keep it short here. But also in this direction, we see developments, for example, like AlphaFold, which enables a tremendous speed up in modeling protein structure folding, which could make drug discovery faster in the future. Then finally, we get to the follow-up stage. And I think an important role here could be for also the large language models. For example, in this study, they showed that using the unstructured reports from radiologists as input, they could use GPT-4 to create a structured report shown here below. And I think this might be a tremendous help for us, because I think we've been trying to focus more on functional outcomes, but it's difficult to get the data, to extract the data from the information that's already there, and having specific cohorts with specific questionnaires is also time consuming and quite difficult to get the big enough numbers. But this might help to extract these types of functional outcomes from just the clinical report. I took something from today's paper, where perhaps in the future we might even be able to predict what someone's going to say using fMRI. I don't know if it's truly feasible. I haven't read the article. Sounds promising. It's in Nature. Might work. So my conclusion of the role of AI is that it's going to be everywhere throughout our treatment plans, throughout the entire patient journey. However, it's going to be a while. There are only very few applications that use AI that are FDA or CE approved, and it's not easy to get there. So I think it's going to take maybe 5 to 10 years before we start to really see these applications in the true clinical practice with outside of the research environment. And to conclude, I think, well, from my perspective at least, the main role of AI is going to be to help us summarize all of the knowledge and the information that is held within the treatment of all of the patients we've treated before, and to apply this and to summarize this for us in a comprehensive and meaningful way so that we can apply it to our next patient and get a better understanding of how to treat and what to expect for the current patients. And I think it's up to us to ask the right questions of this technology and to provide the right data to make sure the models that we produce are robust and work and are stable. And with that, I would like to thank everyone from the Picture team and everyone we collaborate with, also, of course, the funding bodies, for enabling all of this research. And with that, I'd like to finish my presentation and leave all of the challenges and the cons for the discussion, and leave Thomas with also some ammunition for the discussion.